Let's go ahead and get started, everybody. We're a minute and a half past the hour. These sessions are they've been really fun. We've had a lot of good feedback on them thus far. And um, Thursdays at 3, super creative name, uh, happen to be on Thursdays at 3. And they're really designed based on some of the misgivings I had back when I was an administrator. Um, we had all kinds of challenges that we had before us as administrators. Um, we didn't ever know exactly where to go with the questions that we had. And so now that I'm a consultant and have a marketing company we've had for 18 years, thought it would be helpful to just have a clearinghouse for information where we're just openly sharing by topic. Folks can weigh in on the questions that they have. And hey, Patty. And then, the goal is to bring in an expert every week, talk about certain categories. And it's been really fun so far. Sometimes we've done introductions at the beginning so everybody gets to know one another. Sometimes we've got too much content to go through. But today, I think what we'll do is I'll introduce my friend Chris Bonsall, and we'll talk a little bit about Navigate and the most important thing that we can do for patients, which is some education about their options. And then we really want to make time for you to come with your questions because it's not, just about Navigate. There's many ways that you can pre-educate a patient. They just happen to be one that we know well at the practice I worked with, and I've been close with them over the years since they've started. So thanks for joining us. These sessions are recorded, by the way. They're on our website at Margin, and you can review them later or share them with friends. Maybe before we get started, I just thought I'd show some of the things that we're involved with. We do a lot of education through my company, and I just like people to know, where our bread is buttered. And that way, in case we're ever asked about, why we're talking about the things we are, we do think it's helpful to know how to implement new technologies. It's one of the hardest things to do, like I mentioned. But two of the ways we're doing this with our big partners is at the upcoming Academy meeting. We're doing a course in the business of interventional glaucoma. That's October 16th from 9 to 4. It's a day before the Academy starts, and it's going to be content heavy, workshop heavy. So people leave with a blueprint of how they're going to engage patients in a more surgical fashion, yes, drop fashion, where we're truly intervening and getting their progression stabilized before they go on to have their drops maybe managed by their primary eye care provider. The one that's the most rapidly forthcoming is the business of refractive cataract surgery. That's coming up October 3rd through 5th. And Patty isn't doing it right now, but she's about to do this because she's in charge of the curriculum with others who have been on this session before. Really, it's to help practices implement the basics at their practice that need to be implemented in order for patients to really have a chance to really understand what their options are. We think that adoption to premium is really low because patients' education is held all the way until they're in front of the doctor. That's way too late. Nobody can make a $10,000 decision at that moment in time. And so that meeting is put on by ASCRS and ASOA combined. Both of these are actually to help stem the training that practices need to really implement that technology. So look for those. Please come with us, learn more, and they are an investment of time and treasure. But you're encouraged to bring a doctor partner and a team member, and really, it's a grassroots look at how to implement these technologies. So with that, I want to just get started. We're talking about the power of an educated patient, and it's probably a decade and a half ago now that a guy named Topol, Topol, from Southern California, wrote a book with the title "The Patient Will See You Now." Right? It's a play on this whole notion that we used to say, "The doctor will see you now." The dynamics had changed, and it's the patient who needs to kind of work us into their lives, not we work them into ours. And with that comes this notion of who holds the real power. And I think from a risk standpoint, but also from just a pure profit-driven standpoint, there's nothing more powerful than an educated patient. From a risk standpoint, we can get in trouble if a patient doesn't stand their options prior to surgery. Yet a lot of practices don't even bring up premium, and I think that's a risk. Secondly, we believe that, and I believe this to my core, that no matter where you live, 30% should be the low end of your premium adoption, because there's just that many people who would willingly separate with their hard-earned dollars if they knew it was an option and truly understood the benefits and risks of the technology. And so that we're at an industry average of 12% really, I don't think bodes well for how we do as educators. And that's why we have the coursework that we do, is to help practitioners implement those things. Now I'm joined here. You're really here to listen to my friend Chris. He's the VP of Revenue Generation, and all that is a fancy way to say new business and onboarding for practices using a solution called Navigate. And you know, Dr. Thompson uses their technology. That's one of the reasons I know it so well, but I've also had a front row seat to some of the development of their technology, by way of some of the scripting that they use, the onboarding of their teams. But because the whole topic today is about the power of an educated patient, Chris, I'm going to let you describe what Navigate does and how important it is to have that education prior to coming in. And team, we're only going to talk for probably 10 or 15 minutes, and then we really want your questions. So stick around and you can help make this fruitful. And if you don't have some questions, it'll probably be stirred. You'll be stirred by other people's questions. So Chris, take us away. Tell us a little bit about Navigate.
Yeah, appreciate the invite, Matt, and thanks everyone for carving out some time today. So Navigate was kind of founded with the idea that there's a lot of really great solutions out there, a lot of really great ways to educate patients ahead of time. And I'm going to share my screen as well. I got a couple slides for us, but so there's a lot of great ways to educate patients, and none of them are bad, right? I don't think I've connected with any practice in my 15 or so years in the space that has ever said we don't want to educate our patients. There's just been this significant transition towards automation, and particularly since COVID, labor's been difficult to come by. It's been more expensive. And so we've been forced to automate a lot of things in the practice. And unfortunately, sometimes that needle can move just a little bit too far. So we founded the company about 4 years ago. Or now I like to compare it to about 100,000 patients ago that we've touched. And we founded it with the idea that we want to put the human approach back in patient education. We want to put a focus on how do we have a patient that walks in the doors of the practice for their eval, already knowing what to expect every step of the journey, already knowing that there are options, knowing about those options, that they could come with an out-of-pocket potential expense above and beyond what their insurance will cover, and what those benefits might be, kind of truly related to their lifestyle and that unique patient. I love what Matt called this session, the power of an educated patient, because we know knowledge is power. I think we've all heard that term before, and giving the patients the tools and the information they need to prepare for their visit and make a decision when that time comes is really powerful. But in my experience, and the feedback we get from patients, I feel like there's really nothing more powerful than helping a patient overcome their fears and their anxieties that's related to cataract surgery. For a lot of us on the call, we live and breathe eye care, and so cataract surgery is this simple concept that happens all day, every day. And but for a patient, it's a major surgery that is once in a lifetime for them. So I wanted to start with this. I think it's a 45-second or so, really short clip that I think highlights the power of patient education. And as you listen to it, kind of hear the emotion in the voice of the patient, and think, is this something you would like your patients to feel before they walk in the doors of your practice? So I'll start, and if in a couple seconds, Matt, if this audio is not coming through, just let me know.
I want to say thank you to you. I'm really touched to how you're calling, and I'm just a little bit emotional because this is kind of scary to me. I mean, I'm a big baby. When I get my blood drawn, I'm like, it takes me a half an hour to relax and let them draw the blood. I'm just a big, big baby. Mm-hmm. So I really appreciate you calling and going into detail and explaining all my options. And that's really nice. I think that's a nice thing that the company has you doing for patients. That's so nice. I really appreciate it. And I think God bless you. I think you're doing a great job for everybody in the world.
Thank you so much. Thank you. Thank you for your time today.
Okay, you have a good week. You too.
So that's just one example of kind of the feedback we get at the end of every call that a human navigator, which is our team is made up of US-based experienced technicians, calling these patients and spending an unhurried amount of time. Sometimes that's 10 minutes, sometimes it's 30 minutes with these patients before they walk in the doors of the practice for their scheduled cataract consult. And the feedback we get is, that's just one, again, representation of that. But the power I feel there is not only do the educators get that really rewarding feeling of, wow, we're making a difference on this individual patient, but the patient then feels that power that they can walk in feeling like a driver in their own decision, feeling prepared, maybe a little less overwhelmed as well. So, Matt, you asked me to describe a little bit about what Navigate does. So I'll keep going kind of with why we founded the company and then talk about what we do. But as I talk about what Navigate does, I don't really want this necessarily to be a commercial about just Navigate because your practice could do a lot of these things. We could just help supplement if you find a need for us. But hopefully there's some pearls in here you take away with ways you can educate your own patients as well. Uh, Again, I mentioned that in some ways over automation of the healthcare landscape. And we found this study when we were kind of building the business plan for the business. And it was asking consumers across the globe, how much do you feel like when technology advances, we won't need people for great consumer experiences? And like it or not, healthcare there's a consumer aspect to it. And as you'd expect, strongly disagree was the most common response. And I don't know about you, if you've heard me speak ever at a conference before, you probably heard me say this same kind of joke, but it holds really true. Anytime I call Hilton to make a hotel reservation change, or anytime I call the airlines, the first thing I do is raise my voice at the robot that picks up the phone and I say, let me speak to a human. Because it just, to me, it allows me to make sure someone hears my concerns and why I don't want to squeeze my 6'2" body into a window seat and I'd rather be in an aisle seat, right? Getting that human on the phone allows me to be approached with compassion and just feel a little bit more, again, connected. And we feel like the answer is humans need other humans. So here's how we do it. Here's how we think we can provide power back into the patient's journey. And it starts by looking at how that journey typically looks for patients today. And this is a different way to look at kind of that operations experience life cycle that Matt typically shares in the big circle where the top right of the screen is the pre-call. We look at it a little more linearly, where for a lot of practices that we work with, before we get started, the evaluation is scheduled as normal. The patient arrives for their visit. The workup is done. And then somewhere in there, that consultation with the surgeon or maybe with the surgical coordinator just after that, that's really the first time that patient gets a chance to have a true discussion about their lens options, understand how it impacts their lifestyle. They may have went to your website. They may have read the packet that you mailed to them. But if they had questions, this is really that first time they have a chance to have that discussion. So all we're talking about really is front loading that part of the journey, is taking that lens discussion, the discussion of setting expectations, and putting that between the time that eval is scheduled and the time that patient's arriving for their visit. And we feel like the most power can be gained back by the patient by having them aware of those options before they even step foot in the practice.
Chris, just to break it down, just so people can understand, I love the flow, by the way. But basically, patient calls in or the referring doctor calls in with the patient to schedule, right? And they're scheduled by the practice. And at the very end, they say, hey, Chris, so we'll see you next Friday at 10 for your cataract consultation. But between now and then, one of our educators are going to call you. And so the call happens between when the practice schedules them, then an educator from outside the practice calls them before they come back into the practice. That's kind of where the flow is, right?
Yeah, you're spot on and kind of segues into the next slide, but it's that moment of time in between, you've captured them as a patient, and yet for many practices, there's a couple of weeks where they've committed their time to you, but now they're on their own, and sometimes they're going to Facebook, and sometimes they're going to the internet to find out information, which can have its own set of challenges. Instead, as Matt just mentioned, the journey, if you were to partner with Navigate or if you implement something similar on your own, we've found the most success where the moment that evaluation is scheduled, set the hook with the patient. Hey, we're going to be calling you ahead of time, 10 to 12 days, maybe 15 days ahead of your visit, to go over some of the things that we feel like it's important for you to know. In our case, when we partner with a practice, your team doesn't have to notify us. We're automatically notified just based on the fact that that patient's been scheduled. When calling the patient in our journey, we call them about 2 weeks ahead of time. We found that that is really that sweet spot of if they're scheduled that far out, number one, it gives us the highest chance to reach the patient, but it's also close enough to where they're going to remember everything that you share with them. They're going to have a chance to consider their options. They're going to have a chance to think about how it impacts their lifestyle, and it's not going to sound new again to them when they come in the doors just 10 to 15 days later. So in this new journey, this patient, when they arrive for their visit, they're fully educated. You know, there's a kind of level footing, regardless of which referring optometrist sent this patient to your practice, regardless of if that patient watched the video or not. You know that there's that same foundation being laid for the patients and that they're aware of what to expect every step of the journey. We feel like it's really important, as well as I think you'd all agree, is that note has to go somewhere, that the outcome of that call needs to be handed off really smoothly. So the surgeons, number one, don't have to go hunt for it. It needs to be within their clinical workflow, but so that there can be speed to trust built. Because if within that EMR, now your surgeon, after the technician has finished testing, if the surgeon can see a little 3 to 5 sentence narrative, patient's an avid swimmer, they hope to reduce their dependence on glasses, hopes they're a fit for the LAL or for the multifocal, or patient has concerns about XYZ, right? Having that really, really quick narrative allows your team to then build the speed to trust, save time during the consultation, typically 3 to 5 minutes per eval, because they can pick up the ball and start from there. When they see that note, they know that that patient knows what cataracts are. They know that surgery is the next step in the journey, and they know that those patients have been informed of all their potential options, and together they can make the recommendation and determine what's going to be a good fit for that patient's anatomy of their eye and of course their specific lifestyle. I've only got a couple slides left here. So we've now, as I mentioned, seen about 100,000 patients come through Navigate, where we have had a US-based COA, COT, COMT call these patients and have a dialogue with them in real-time one-on-one discussion. And what we found is part of the reason we're calling patients before that eval, they make stickier visits. They make stickier patients, rather. So they're more likely to keep that appointment. If they're spending 10 to 15 minutes on the phone with you, your team, or us as an extension of your team, that patient is going to feel really, really thankful. As you heard from the call I mentioned at the beginning, they're going to be thankful that you spent that time with them, educating them, asking them what their concerns are, discussing their fears, and really just getting them comfortable with what the next couple steps of the process are. Because there's really nothing scarier than the unknown, right? So we've seen double-digit reduction in cancellations and no-shows. We've also seen an increase in patients proceeding with surgery. So just we know that there were studies done in, I think it was 2020. A third of all patients across all specialties would put off or cancel a procedure just because of fear and anxiety. And so we've been able to see a meaningful impact in reducing those patients that aren't ready to make a decision or aren't ready to schedule surgery. And we've seen a growth in what we call surgical capture rate, just the number of patients moving from evaluation to surgery. And then the last piece, and certainly not the most important, but one of the ones that's easiest for most practices to track, and as Matt mentioned, I think where there's the most room to grow is the adoption of premium lens technology. If you're educating your patients ahead of time, or if you're choosing to, again, partner with a company like Navigate, the goal is not to sell or push patients towards premium lenses, because to be frank, nobody really knows if that patient's going to be a good candidate before they walk in the doors. But it's our job to educate those patients fully so that they can make the best decision for their lifestyle. And what we found is more educated patients are time and time again more willing to invest in their own vision. And that tends to be towards premium options. So we've seen 30% higher premium adoption rates for patients that were educated by a navigator when we compare them to those patients going through the standard education process.
And Chris, with that 30%, is that an aggregate of all 4 months? Because it looks like, because month 4 seems like it would be more than 30%.
Yeah, so true. It's on average an aggregate of the 4 months. Yeah, sorry, I didn't understand.
Right.
Yes.
And the reason I say that is because there's, clearly there's a ramp up where a practice is enjoying, the benefit of an increased adoption rate, a lower no-show rate, and an increased total movement to surgery rate. But if you were to annualize, the 8 months following the 4 month, at least I'm just going by the numbers there. by the visual there, it looks more like 45 or so percent increase. And I'd just be curious to know what you think the numbers are to go with that chart if we did it
Yeah.
that way.
Yeah, you're not far off, I imagine there, Matt. I mean, the way that we look at it is uh, we're always doing this A/B testing every month. We're comparing the patients that came through our process versus the patients that we just weren't able to get a hold of for whatever reason.
Mhm.
And yeah, some months that number is closer to 45% higher. Some months it's closer to 25% higher. So, we're seeing that kind of new benchmark be somewhere north of 30% higher. Um,
Mhm.
but it takes a couple months. Yeah, we got to wait to see those patients coming through, because for any of you listening, if you invest in this type of service, or build it out yourself, there's a little bit of lead time. You're calling the patients ahead of time, then they have to arrive, then you have to wait to see them come through surgery. So 6 to 8 weeks later, you start to see that funnel increase. You start to see the surgical revenue increase as well.
Yeah, that's great. And Chris, I'm going to let you keep on me. Oh, sorry about that. Sorry, I was gonna go to some questions, but do you want to give these 4 points here quick?
Yeah, this is going to be my last slide actually, and I'd love to take some questions. The why should I consider a change, right? We're here talking about educating patients, which I think again at the beginning I mentioned I've never had a practice say they don't want to educate patients, but a lot of groups would say we do a really good job educating patients today. I totally agree, but there's always more that can be done. And so why you should consider it, I think, is one of the things Matt mentioned at the beginning is that risk that some practices face. And I still hear this often on my first call with a practice is the worst thing you can hear is a patient say, man, I wish I knew that was an option before I had my first eye done. Or why did you not tell me about this option that my neighbor got? And it's a big concern. Um, Also time savings, right? Educating patients up front, that you're spending time that would otherwise be spent with the patient in the office. So if you're saving even just 3 minutes per evaluation, that's 2 hours per surgeon per month. That could be used to add more schedules, more blocks on the scheduling template. It could be used just to give some time back to your potentially overburdened team as well. It does mean real dollars. Practices seeing 40 evals a month, that could be easily $10,000 or more in increased premium revenue. And then, if you consider to change to a company like ours, where we can be an extension of your team without requiring you to hire more people, it does take a burden off of your already overburdened staff. We've partnered with some groups that have tried to do this on their own. There are many that do it really successfully on their own, but for practices that have had challenges with staffing, uh, you know, partnering with a group like ours that allows you to take advantage of a bullpen of team members that are available to call 7 days a week if necessary. That's something that has helped reduce the burden on the existing team while allowing you to scale your cataract business as well. So that's all I have in the form of slides, but yeah, absolutely happy to take any questions and hear feedback.
Yeah, that's great. I thank you for showing us those pieces. And folks, listeners, one of the things I'd like to do is maybe ask Chris questions, but also share kind of how you're trying to do pre-education at your program. Go ahead, Patty.
I have a question. So we worked pretty hard on this, and we were proud of carrying about a 57% capture rate. So, and we're very proud of that. But one of the things I wonder about is, of course, pre-education is the most important thing, I think, because they have to come in with a little bit of knowledge or they're just overwhelmed. But are you using anything, Chris, that is virtual visual, or is it all just voice?
Yeah. So our education is done through dialogue. We will use, so what I didn't touch on is when we partner with a practice, it's about 21 days to personalize our approach to what that practice uses. So any of the content that they're using today could be videos, could be a packet, could be links to their website. We will help to make sure not only are we reinforcing it with their team, but to get it in the hands of the patients. But our content, unless the patient requests a video call, is almost always a phone call dialogue in real time.
Okay.
Patty, I think to that point, it'd be awesome if it was supplementary, right? I mean, for different styles of learning, we should hit them as much as possible. I know that just having run a practice, we were counting on our phone team to do so much that even as I secret shop practices now, the amount that we're expecting them to do, it's easy to just say, well, we'll just have them do that, while they're in between calls, right? Like it happens magically that they've got that time. Meanwhile, we don't allow any kind of there's no forgiveness or soft spot for not getting their insurance just right, their demographics just right, um, and other
Yeah.
prep that has to happen for pre-authorization. And then once they are running perfectly, which they don't do, then someone is sick or actually has vacation. And so then what do you do in those cases as well? And so I
Yeah.
think that it's tricky.
This is these particular patients I feel are obviously they're a higher yield revenue wise, and they require a little more kid gloves in their handling, and many of them don't want a callback or don't want to have to leave messages.
Mhm.
They want the information when they want the information.
Yeah, that's a good point.
Yeah.
Chris, you've worked with a couple of doctors who I would have gone into their practices as a consultant and said, "Well, I'm not sure your adoption of premium could be higher, right? You're in the Midwest, you're at 48%. I mean, my goodness, what more can we do here?" Yet you've got one that you had a white paper on, and then one recently that's finishing kind of a 90-day piece whose, names, one I can talk about because it's Vance and he's my friend, um, who even at 48% is growing that amount and decreasing his no-show rate. Um, but the other one out of Kansas City, I don't know if you're willing to share, um, their increase, but just that little bit of pre-education helps.
Yeah, I would even kind of generally speaking, we have you ask a practice their premium adoption rate and you usually get one number. But what's interesting is there's a mix in there too, right? Like let's just use a round number. At 50%, maybe you have 50% these patients are choosing some sort of premium technology. 40% of that is laser adoption with a toric or laser with a standard
Mhm.
monofocal. You can do a lot of value. You can drive a lot of value, even staying at 50%, but increasing the mix in there, right? So there's a lot of opportunity in there. So that's one way, right? The implementation of new technology, groups bringing in laser for the first time and just not knowing how to talk about it, or groups bringing in the LAL for the first time because we work really tightly with a lot of our industry friends, and trying to help practices implement new technology and learn how to talk about that. The group you're referring to, high volume practice, we saw high 20% growth for each of the 7 surgeons we supported there, for the first 16 months, and then it kind of levels out and you find the new benchmark, the new baseline. At some point you kind of reach that ceiling, but our job is to keep them there. At that point, the value is, in the eyes and the words of the surgeon, is I used to spend 100 units a day educating patients as a broken record. And now I only have to spend 10 units a day because 90% of those patients are walking in the door fully educated from Navigate. And the few that I have to
Mm.
go and educate myself, I can feel more refreshed. I can spend the time educating them on what I need to. And so it's kind of a combination of those things. Like, we look at premium as one of the key indicators of how successful education is. But again, reducing burnout, which we know is huge right now, reducing the time being spent, and potentially being able to increase the volume that we can keep up with, because we know there's more patients coming in and less surgeons going to be available. So that's going to be a continuing problem that grows as well.
Yeah, that brings up an interesting scenario because we're friends. I hear some of the objections practices have, right? I mean, one is, hey, that's expensive. Why don't we just do it ourselves? What would you? And by the way, that's what I would have said. So, I know I would have, because that's the kind of thing that I did say.
Yep.
What do you say to folks like that?
Well, I don't try and deny it. I mean, we're not an inexpensive solution, and I would argue if you were to do it yourself, it's not an inexpensive way to do it. But it's a great way to do it, and it's something that drives positive returns, right? It's back to my earlier point. We can automate things, right? And we could go to a video platform and spend $200 a month and throw that out there where every patient's getting the same thing, and you hope it hits, you hope they understand it, and you hope they open it. but a labor cost and putting truly experienced experts on the call with your patients, yeah, it's not it's not the same cost magnitude of a video platform, but they've at the last BRICS meeting, the very first Business of Refractive Cataract Surgery meeting, we had a practice that wanted to partner with us, and they had the same feedback. Hey, you're very expensive, so we're going to do it ourselves. 7 months later, they had 2 people in that role. They tried to reach it. They were only educating 50% of patients because the patients would call back when those technicians were seeing patients. So then it was a game of cat and mouse, and you're constantly chasing those. So then they partnered with us 2 months ago. We just got them live, and we're really excited to see what those results drive. Where now they've got a team of people at the same or less cost than they would have paid their own employees, healthcare benefits, hiring, retraining. Instead, they're paying us
Yeah.
the same fee. They get 4 or 5 people assigned to their account, where if someone's on vacation or gets sick, that education machine is still going because you got a bullpen and you get that economy of scale of partnering with a third party. Um, so that's again, I wouldn't deny the fact that it's not cheap to use people to
Yeah.
from, but it's the right way to do it and grow. And when you see a return within 45 days, it's generally easy to look back and say we made the right decision.
Well, and I confess, I would have said that, but I would have also not got it done because of competing interests, not because my intention wasn't to get it done. My intention would be like, I can do that myself, and I will. But it's just one of competing interests of other things that take the priority, either mine or the team member that I'm bringing in. Kelly, I saw you unmute.
Yeah, Chris, hi. I had a question for you just on what it looks like from the patient's perspective, what these calls look like. Do you guys act as an extension of the practice itself, or are you saying, hey, we're, calling from Navigate and we're going to talk about lens options? So I'm just curious to know like that on the front end. And then I noticed in your presentation that there's an ability for the navigator, as you call them, to put in notes to the patient record. So is that kind of the best way that things are communicated? What if the patient has, inevitably other questions that don't have to do with the lenses, but they want to know, what happens after surgery or whatever, and it's not something that your team is, maybe they're aware, maybe they're not, but how personalized is that communication with the practice itself?
Yeah, appreciate you asking. So we learned a lot of lesson early on, and that's one thing that in the first year of our business we really put a lot more emphasis on. So I think I mentioned about a 21-day onboarding process, and the goal of that is, sure, we could sign up a practice today and start calling their patients tomorrow, but we take that 21 days to gain that alignment and really personalize. And sometimes that personalization is by surgeon, even within the same brand, because they may have different options that they like to use. They may have different turn of phrase that they like to use. So to answer your first question, when we call a patient rather, each practice we create a local area phone number, so a unique personalized phone number that we call from. So it will show up on the caller ID as cataract education, and so they can always call us back. That helps us to reach more patients, less spam blockers. We never tell them that we're from Navigate. We do treat ourselves as an extension of their office. I'm calling on behalf of Dr. Smith today to talk about some of the things that she's going to want you to know. Because frankly, it does us no good if a patient says, I really appreciate Navigate spending this time with us, right? The video that you heard me play at the beginning of this call, in that patient's eyes, as it should be, that practice spent the time to alleviate her fears and get her prepared for her journey. So we really become that extension of your team. Um, and then the last piece, part of that onboarding process is also a long list of frequently asked questions that we've continued to curate as we work with practices. So if a patient says, hey, do you validate parking? Is there an elevator because I can't walk too far? How many steps is it from your parking lot to the front door? We know those answers. So if a patient says, oh, am I going to see you when I'm in there? Our answer is, you know what, I actually work in a virtual call in a remote call center, but you're going to be in great hands. But every other question we can answer as if we are sitting within the 4 walls of your practice. Um, if they're clinical in nature, and that's why we hire experienced technicians, because frankly, we could do it cheaper if we just hired someone who sounds great on the phone, but we want to put someone on the phone with a patient that if they say, you know what, I'm post-refractive and I had X number of cuts years ago with this, we want our people to know exactly what that means and be able to answer the patient's question as if they're to calm their fears. Um, And so all of those things we've done, I think, really well to make sure that we sound like an extension of your office and we don't break that fourth wall. Did that answer? I know you had a couple questions in there. Did that?
Yeah,
Yep.
no, I did. Thank you. You did answer them. Appreciate it.
What other questions exist out there? I've got another one in the barrel, Chris, that I'll ask, because the other thing I hear practices say is, hey, so we've been working with you for a year, but now we don't see any growth. You're steady now. Shouldn't you be growing like you did over those first 4 months?
Yeah. It would be great if we could see, 30% year-over-year growth, right? But there's only so many things there's always going to be that ceiling. There's going to be the patients that aren't going to be a candidate. There's going to be some cap that we're hitting. But our goal is when we grow that practice's surgical capture rate and premium capture rate, take them to that new benchmark. And unless other things change, right, adoption of new technology, pricing, macroeconomic environments, typically that becomes your new benchmark. Just like before practices work with us, typically year over year, they have a very similar historical benchmark. We're teeing it up so that the surgeons can drive it down the fairway with a strong recommendation and confidence in their surgical plan with the patient. Uh, and then, again, that takes them kind of to what their new benchmark is. Val, I saw you on mute. Did you have a question?
I did. Yes, and I know you're a little familiar with our practice, Chris, and we were one of those two that said, we're just going to go it alone.
I wasn't going to call you out by name, but thank you.
Yes.
It's every
I'll
practice.
confess right away. And I will say, 3 years ago, we had a better premium conversion rate than we do right now, but we also have a higher cataract volume. And I'm trying to figure it out. We have a healthcare center. They blast their ophthalmologist, so we're getting all their patients. And we probably have a different philosophy in our practice where we start educating our patients, 50s, for sure, mid-50s, we start talking about different options for them, and we can kind of feel that weight with our patients now that we've been doing it that long. These patients are coming in that's giving us higher volume, but they know nothing. And trying to educate them, and it is that time factor a little bit. We've had change with our counselor, and so I'm just kind of at a point where I'm trying to analyze where's the problem at. She's probably not, she's not going to dive into them and, necessarily sell them on the plot. I mean, I think she does to some degree, but she's not going to probably work it as much as our other counselor did. And as we all know, we probably can't retrain that way of approaching patients, but and we do use the steps. They see the optometrist, and from that optometrist visit, they're educated in between, and then they're called by the counselor as well. We do use some video helps. We really, I don't know what the rest of you think, but I really feel like I kind of agree with that. The dialogue, that live voice, you tend to get better results with them, but it is that getting a hold of them. Nobody wants to answer their phone. I'm watching
Val,
crisis.
if you don't mind, I'll take a shot at just answering at least part of your question. And first of all, you've got a good surgeon who does a good job
Right.
of talking about the technology.
Right.
So that's always going to be king, right?
Right. Mm-hmm.
But the idea is to figure out how can you very consistently get the information upstream as much as possible.
Right.
And the first thing I want to talk about with that is that even though you've got a new influx of patients, the reason I brought up that percentage at the beginning is because I don't think that new subset of patients suddenly wants to see more clearly at a lower rate.
You wouldn't think.
You wouldn't think. I mean, that there's a pocket of people. The people who
Right.
don't want to see much are over here. The
Right.
people who kind of want to see well are over. I mean, it doesn't work like that. And so there is an educational piece to this. And so part of that is how do we do it in a way that's trackable, consistent, and And so navigate or other solutions could be helpful
Right.
there. The other thing is that, and this is going to be what Patty works on or shares at the BRICS course. But the
And I was just gonna
counselors,
ask about that, if that's something I should
yeah,
think about, you know, starting with some of the team, bringing them there.
what she'll tell you, and I'll tell you, is that the counselor plays an important role in doing what the doctor suggested.
Mhm.
The recommendation comes from the doctor.
Right,
And the counselor doesn't do much for they don't upsell. They don't do anything. You say, well,
Mhm.
the doctor recommended X. So I'm here to help you make that happen from a pricing standpoint. Like
Mhm.
here's how you can use paid financing, here's how you can use your FSA. But because the Dr. Fisher is going to want to be the one who makes that, you know,
correct.
we
Mhm.
found that you've got uh cataracts. Based on how you say you want to use your vision, my recommendation is that. And Val's going to help you schedule that and make it work within your lifestyle.
Mhm.
But so those are the things I just wanted to mention there.
Mhm.
No. So I just wanted to say on that, you know, our counselors in our practice, we really educate those patients up front, and we tee the patient up with the thought of what they want based on the education. So that, and we congratulate them on making a choice. And then when they get in front of the physician, it's
Mhm.
just a matter of the physician agreeing with their choice and saying, you've made a great choice. It's going to work great for you. So it works both ways. And with Chris's educational component, the more you educate up front, the easier it is to do that. So that when the surgeon gets in front of them, many of them are ready to just, I hope he says yes. I hope I can have that light adjustable lens, right?
Right.
Chris, a couple of questions came in on the chat. Do you mind tending to those?
Yeah.
Kelly was asking, do your callers does pricing get discussed and financing options?
We do. We discuss pricing. I apologize on any background noise. We discuss pricing with every one of our practices except for two surgeons that are steadfast in their ways that they don't want their patients hearing about pricing. We've shown that it has helped to increase kept appointment rates because patients now feel like that's a big part of the education they want to know. And we will talk about financing options if you have it available. Now, to be really clear, we're not going to the penny. Right? Our job is not necessarily to look at their insurance and run that, but we want to set the expectation that, hey, for this option, if you go down this path, roughly $2,500 out of pocket above and beyond what your insurance deductible will be. And the practice, has financing options, 0% down, maybe $180 a month, so that they know at least a ballpark area of I got to go in, make a decision, and some of those decisions are going to cost me something, but it gives me the best of getting out of glasses potentially.
Yeah, good. It's a good question there. Chris, you've got a client on the phone. I didn't know that. So we get to see in real time how things are going for Margie. She says she'd like to give input on how it's going.
I'm gonna get fact checked.
Fingers
Is
crossed.
that okay? I don't have my camera on. I want to make sure you can hear me. I've got some
We
background
can.
in the lanes. So I'm listening to all of this, and I have to be very transparent. I just dialed in on the call because I just wanted to hear additional information. And so I thought perhaps you might want to hear from a practice who recently utilized and implemented Navigator. We started back in April and we trialed 2 surgeons. And we have found it to be so successful for our practice that we just onboarded a 3rd. And I can't tell you enough about just the communication that we have with Navigator. NEPA, who I work with, we had our onboarding calls. We fine-tuned some of the talk tracks, if you will, very specific to each surgeon. The surgeons love it because now we're finding the patients are coming in. They have a good idea of how they want to proceed if they're a good candidate. We find that the chair time has decreased. We have found that we call them surgery schedulers, but I mean, in my old practice, we were counselors. We actually are able to just solidify and know something about those patients because we're able to look at those notes too that they put in for the patient before the patient ever walks in. So what it's doing is it's building that relationship at that very first call with our patient educator. And then we are able to just build upon that. We have seen some increased conversions. And a lot of it just has to do with the patients knowing firsthand before they walk in what the appointment's going to be, about setting those expectations, knowing what the pricing is, having somebody say financing is available. Some of our patients come in with their care credit accounts already set up now, just so that they're ready to move forward. So we have seen a decrease in chair time and an increase in conversion, but more than anything, we have seen our patients happier, that when they're coming in, they're not so overwhelmed, and that they're hearing about all of the possibilities before they walk in. And there's something to be said about that. That's just, I think, absolutely huge. The other thing, Chris, I didn't hear you say, and maybe I missed it, but Navigator also has Spanish translators available. And that's huge for our patients too. So if there is an instance where we need one, then somebody can talk to that patient. Chris, I'm correct in that, right? I just can't remember if we've had a patient yet that needed one.
Yeah, so we currently support actively English and Spanish. So we will assign Spanish navigators to practices that have a high volume of Spanish-speaking patients, and then just ad hoc for patients that need it. We are now going to be educating in Russian as well for a new practice, and we hire to need based on language needs as well. And also, thank you for the kind words, Margie. We
Oh gosh, no.
Margie,
So
I
again,
was so nervous. I was so nervous for Chris. It was like a drum roll.
oh gosh, no. But
It's like,
I'm
where's this
hearing some of
going?
the questions. I hear some of the questions that others have, and so we have firsthand experience with it. And so I thought it might be nice to hear that from somebody who is really very pleased with where we are right now.
That's excellent. Thank you for that.
Yes, of course.
So listen, we really commit to trying to make these about 45 minutes long. It's a great segment. Chris, I can't tell you how great it was to see a dashboard of some of the numbers. And by the way, to keep it concise on 3 or 4 slides is really a feat. So thank you for that. Everybody who's attending, I really want you to know how I hope you're enjoying these sessions. I see a lot of names on here who've been on here before, and we want to continue to get people, to hear about new sessions. We promote them on LinkedIn, but otherwise we don't promote them too hard. So please, tell your friends and colleagues. Our next one is next week at 3. It's with our friend Ben Seals, who's the CEO of Thomas I Group, and he's going to be talking in particular about how they've been implementing interventional glaucoma using a data approach, meaning he's just mining his own database for surgery. And it's been really successful for him. And some of the tools and tips that he has that are going to be presented next week. We hope to see you all back here for that. And if you don't mind, we're doing this for nothing. We're doing it for free. We just want to get good word out of how to implement things. Share this stuff with friends and colleagues, and bring them to next week's session or the other sessions we promoted earlier in the talk. Thanks everybody for coming. Thanks for being good listeners. Chris, good job. We'll see y'all next week.
Thanks, everyone. Thanks, Matt.